So I want to take a moment here to welcome everybody to our first hybrid in-person grand rounds. Today is July 6th. The activity code for today's session is listed there for you. I'll be going over some information here in just a second, but if you are registering for CME credit, please make sure you do so before midnight tonight. Let's see here. So for those of you who have not yet registered, you'll need to make sure that you do register your email address to the toll-free number listed there. Once you've done that for each of these sessions, you just need to text attend and then the activity code for that day to that toll-free number. But if you have questions, I'm happy to help. So as we go ahead and get started here, if we could, please, if you are on Zoom, just make sure that you do mute your microphone as we go ahead and get started. And for everyone in attendance, if you could please make sure that you are attentive and engaged in the session. And then towards the end of the session, I'll put it in the chat box and I'll actually email that to everybody. I didn't even realize I should have printed some for those who are here, but we'll need some feedback to give to our presenter if y'all can help us out with that. So this is the South Texas Regional Family Medicine Grand Rounds. We're partnered with the AHEC and our mission statement is there for you. For those of you who are claiming CME, please make sure every so often to check your CME transcript, make sure that you are getting credit. You can do that by visiting the CME website listed here, but also, of course, if you have any questions, you can still always contact me as well. Also, we are offering AAFP credit for this presentation, so keep that in mind. And we are wanting to make sure that we mention that we do try to reach these nationally established physician core competencies in our presentations. So with that, we will mention that Dr. Sobolevsky has no financial relationships with ineligible companies to disclose. So he's presenting to us today. He's going to be presenting, oops, wrong one. Treating common foot and ankle issues one step at a time. So I'll let him go ahead and take over here.
Well, thank you very much. Does it amplify? It's just, okay. Well, thank you very much for having me. I'm Dr. Sobolevsky. I was a student here. I was a resident here, and now this is 4th or 5th year as an attending, and I've worked with a lot of family med attendings as a resident and also as attendings. And I see Dr. Palacios, Dr. Falcon, great, wonderful people. I've learned a lot from them, and I've send them a lot of patients as well. So, you know, obviously I deal with two specific areas in terms of the foot and ankle, but in San Antonio, it's a lot of times it's related to diabetes, but we'll knock out some of the most common things that you will see or that we get referrals for. So our objectives are just to accurately diagnose and evaluate common foot and ankle conditions, discuss common treatments, and determine whether we need to consult somebody else. So these are the topics that I want to cover today, which are probably the most common things that you'll see in a clinic. And I'm assuming. So first, let's hit up plantar fasciitis. Probably pretty common. Heel pain. Patient comes in, I can't walk. First step in the morning, they point to the bottom of their foot. 95% of the time, it's plantar fasciitis. All right. So once again, does this point? Maybe. Oh, here we go. So usually, the plantar fascia attaches to the medial tubercle of the calcaneus, and then it fans out. Most time that pain is right there, like around the distal fat pad. And if you're not having enough, thank you, sir. Oh, much better. And so most time if, patients complain first thing in the morning or something called post-static dyskinesia, sitting in the car for a while, watching a movie, they get up, it's painful. And I jokingly say, okay, I'll have you sit here for another 2 hours. I'll come back. We'll see how you're feeling. It's obviously a joke, but patients will say, that's not funny. I've waited 30 minutes already. But yeah, most of the pain is here and it extends distally. Risk factors: tight calf muscles, obesity, very high arch, overpronation, repetitive impact activity, new or increased activity. Once again, that pain, pretty pathognomonic for like right in the bottom of the heel, pain first up in the morning, and things of that nature. So this is where, this is from literature, non-surgical treatment, more than 90% of patients with plantar fasciitis will improve within 10 months. Not in San Antonio. Our patients do not get better. I'd probably give it at 75 to 80%. A lot of patients are obese or just non-compliant. Usually in a good, healthy patient, if you, rest, ice, NSAID, stretching, injections, supportive shoes, those are all helpful. Do I get x-rays for this? Nah, not often, but it does help rule out other causes of heel pain, such as fractures or arthritis. Usually, when we get referrals for heel pain, you guys already get the, oh, perfect. Thank you, sir. So, there we go. So we get this x-ray and boom, this little nugget. I'm not worried about that nugget, that heel spur. That is rarely the cause of plantar fasciitis or the heel pain. This, here you go. Although many people with plantar fasciitis have heel spurs, they're not the cause of that pain. Even when we do surgery for this, we don't address this issue. The issue is the tight plantar fascia. Okay. So there's nothing worse than a patient comes like, are you going to cut that off? I'm like, no. But why? Well, because we don't need to. And literature time and time again says you don't really, this is very, very rarely the cause of that heel pain. Sometimes in some cases, this does point more plantarly, then maybe I'll shave it down. But in cases like this, really, it's the tight fascia that's still the cause of the issue. The tightness of that fascia pulls on the calcaneus, forming that spur. And a lot of times when you have a tight Achilles, you also will get a little spur here. And in this case, you can almost see how usually this is a little bit more rounded, but here it's beginning to sort of pop. And sometimes patients do have a posterior enthesified in the Achilles tendon, which is also, that could be more actually troublesome or problemsome than this heel spur. Whenever you order x-rays for foot and ankle related issues, well, for the foot, weight bearing, 3 views. Unless they can't bear weight, that's a different story. But weight bearing is the best way for us to visualize anything that we need to do. Weight bearing, 3 views. If they can. If they're for foot, one side is okay. If you're doing ankles, sometimes bilateral is needed. Sometimes for just baseline, I'll order bilateral films just to be thorough. What's that? Yes. A lot of times especially with plantar fasciitis, a lot of times it is bilateral. What happens is, they come in with right foot pain, then they start favoring their left, and then they develop pain on the left side. Same with the ankle, and a lot of times patients will, especially once again, with plantar fasciitis, the pain is medially, putting more pressure laterally, and then they develop lateral foot pain, and it's just a matter of compensation. So for me, not to say that I didn't quite exactly put my treatment plan up there, because not to say it's proprietary information, but I'll tell you the way I do it. Let me see if it's on the next slide. Okay, maybe it is. So differential diagnosis, calcaneal stress fracture. Will you see it on x-ray? Probably not. Right? It takes a while for stress fractures to show up. If it doesn't even show up on radiographs, you'll need an MRI. Rarely the case. Bone contusion, Baxter's neuritis, and lumbar radiculopathy. So now, pros of wisdom. This is the way I do things. Start very conservatively, because many patients will improve with simple lifestyle modification, different shoes, supportive inserts, avoiding being barefoot, simple stretching. I took my treatment plan from the foot and ankle doc for the spurs. If it's good enough for them, it's good enough for me. It's good enough for our patients. Start conservative, inserts, lifestyle modifications, then I go with the Medrol dose pack. have a patient come back, most likely I'll hit him with a second round of Medrol, and then if needed, do a corticosteroid injection. I don't start physical therapy until the pain is less than a 5 out of 10. Why would I send them to physical therapy if they're still like in acute pain? The Medrol will help calm things down, especially if they're, begin with supportive shoes and inserts. Then physical therapy is beneficial. Now, corticosteroid injections. I sort of use my own little mixture, and throughout my education and training and, being as an attending, I've mixed around with, lots of solutions, formulations, and I've come down to a little bit of lidocaine, a little bit of dexamethasone, a little bit of Kenalog. I call it my 3-punch combo. Lidocaine, they'll feel immediately better upon leaving. Dexamethasone, faster onset, shorter duration. Then the Kenalog hits, which takes a little longer to start working, but has longer duration. Okay, and actually in the double AFP, they sort of inject similarly to the way they have their, like the musculoskeletal injections. I really like to hit the target area, the pain where they have the most tenderness. And then I hit that area, then I fan. I always go immediately, never planarly. Planarly is just pure torture for the patient. So give them a patient 5 minutes, they'll feel the lidocaine. It's like, oh my goodness, I feel much better. I'm like, yes, you do. And then, and I've changed it up throughout the years, but this has been my most consistent injection: Lido, Dex, Kenalog. So physical therapy, yeah, exactly, is very helpful, but only when acute pain has subsided. If treatment plan is not succeeding, consider another diagnosis. So in our population, obviously peripheral neuropathy and lumbar radiculopathy. I had a patient coming in with heel pain, gave him Medrol dose pack. They feel better. Okay, give him another one. All right. Give him an injection. Injection didn't work. Like, it's a targeted injection to the plantar fascia. No, the issue was lumbar radiculopathy. All right. So this is the least most disgusting part, I guess, of the presentation. I guess diabetic. Yes, sir. Correct.
And then there's a variable amount of time that the steroids actually help them, right? So for the long term, do you really feel like it gives them a big benefit, 6 months?
That's a great question. Every patient is different. I usually do my injections every 3 to 4 months. After a certain point, enough is enough. I'll get an MRI. A lot of patients have a good amount of relief, and then they, it depends how long they've had it. In acute cases, this works great. In patients that I've never seen, they've complaining of this, condition for the last 5-10 years, like a chronic. Okay, injections can help, but to a certain degree, get an MRI and then evaluate whether they need surgery. A lot of patients, they'll get relief from the injection, but they don't do anything in terms of lifestyle modification. They're still barefoot, they're still in flip-flops, and then, depending on the right patient, then surgery is indicated. And surgery, to be honest, is actually, it's pretty straightforward for me. Patients do very well with it, but still, I wouldn't use a patient as a pincushion, but every 3 to 4 months, I'm okay with, especially with our patients who can't take time off, who have to continue working, whether you're, seeing patients at RBG or my other clinics at Texas Diabetes Institute, they can't take time off. They can't work in a boot. And that's where it sort of differs from the patients at the Texas Center for Athletes, where Dr. Allen sees patients. I can't be like, I'm sorry, you got to take time off. So I tend to be a little bit more lenient with our patients, like, because they can't take time off. They have to make money. So I tend to be a little lenient with that, but maybe one more injection, or maybe a little shorter time frame to get them through.
Said that custom orthotics were needed, but that's a pretty good success with just going to the counter and try to fit them. What's your feeling about?
I will get to that question, Dr. Nadeau. I promise you there. We will get there. Next topic is, if anybody has an question, whether online or in person, don't hesitate to interrupt. and we'll go from there. I'm always willing to answer any question. Next topic, onychomycosis. Once again, you guys have seen this in clinic all the time, very common in our diabetic patients. It's also very common in just young athletes. Anytime you have toenail trauma, that nail plate splits and lifts up from the nail bed, little fungus scurries in, and bam, you get this little nasty booger. Okay, very common. I don't agree with a lot of the literature about this because we see this all the time. I don't know about the local pain paresthesias, difficulty performing, activities of daily living, but patients really are concerned about the cosmetic appearance of it. Sometimes the thickness, the bulk can affect, depending what kind of shoes they wear, whether, it can cause ingrowns, but usually it's this, the cosmetic, the aesthetic appearance. I don't, decreased quality of life may restrict. Yeah, they're quite unsightly. The thing is, we're dealing with a lot of patients that are, very common for the advancing age: diabetes, immunosuppression, cancer, PVD, psoriasis. And usually in younger patients, it happens because there's trauma. Anytime a tight fitting shoe or you're running, you're still buckling, boom, boom, boom. And then that nail plate lifts up a little bit, fungus scurries in. Anytime when people injure their toe, it's usually the big toe, right? They drop something, it's always on their big toe. What happens is they injure the nail bed, and then the nail doesn't sit flush, fungus scurries in, boom, you got onychomycosis. So in a younger patient, it's easier to treat because it's just the longer they've had it, the harder it is to treat. And so there's lots of different, ways of treating it and getting rid of it. But the really is, it's really hard to completely get rid of it. You might never get rid of it. It might never get any better. It's a very fickle and thing, and it's very difficult for patients to accept that they'll never have clear, beautiful nails again. Some of them, majority of them will not, because it's, to get rid of it to its normal state, very hard. Some patients, some docs will take cold, take a piece of nail, send it to get fungal cultures. I don't. You can see what it is. It's boom. This is fungal nails. You have the subungual debris. You got this discoloration. You have the thickening. So topical stuff. Cyclopirox 8%. It's a nail polish. You put it on once a day for 8 days or 7 days, and then you file it. Jubileet, they're also newer therapies, very expensive. I don't think they work that well either. I actually like to use the cyclopirox cream, which is 0.77% BID. I think it works better. And plus, it can also help with, a lot of times these patients have concomitant tinea and so they can use it on both. So there are no strict guidelines. 48 to 52 weeks. Treatment efficacy is enhanced by treating early and often. Okay. But yeah, usually you want to, topical is good for patients that you want to avoid any drug interactions in our, diabetic population, who also takes a bunch of medications as well. Oral medications, you have your terbinafine, 250, 6 weeks for fingernails, 12 weeks for toenails. I tend to be pretty conservative. I check liver function before, in the middle, and after treatment. And you got to advise patient that, listen, it's not at 90 days, it's not going to miraculously I'm not a magician. It's not going to miraculously go away. It's going to take time for the toenail to grow out, up to 9 months rather. There's also itraconazole, with the sort of like a pulse dosing, and then there's terbinafine pulse dosing as well. I usually stick to this one. Boom. Really 90 days, at 6 weeks, have them come back. You should start seeing a nice clear delineation, and then get them repeat hepatic function labs and go from there. So there's no approved therapies for kids. Oral terbinafine and itraconazole are often used off-label. There are other, and even lab testing there's no recommendations for therapy and frequencies are lacking. So that's just the way I do it. I'd rather be safe than sorry. And you'll hear me say that multiple times during this lecture, but very much, that's the way I do it. I want to make sure that I don't kill someone's liver because they want to have pretty toenails. Onychomycosis paronychia, ingrown toenails and infected, growing the infection that, predisposes it to them. You guys see this all the time. I think there's a procedure clinic, right? So lots of different causes. A lot of times it's because of improper cutting of toenails and external pressure secondary to poor fitting footwear. Now, the onychomycosis, the ingrowing part, the paronychia, is the infection that can follow it. Now, there's lots of different reasons for it, but let's see how we're going to treat it. So this is a mild case, right? Mild case. This is now, not great. No worries. And this is oh boy, what am I going to do with this one, right? In this case, the patient comes in like this to my clinic. This would be a good, patient for permanent partial nail avulsion with phenol matrixectomy. This one, too inflamed. I would do a partial nail avulsion, but let it grow back out. In this case, I'd rip the whole toenail out, take out all this granuloma, and just give it time. Now, in a patient like with an inflamed like this, I personally don't think that, I don't know, do you guys use phenol in clinic? I don't, in an inflamed situation like this, phenol doesn't take well. Actually, local anesthetic doesn't take well either. So sometimes when you're doing your hallux block, you might have to give a little bit more. In case like this, phenol is going to work perfectly. In cases like this, it is a bit too inflamed for my liking. I'll once again block. And then I like to use a beaver blade instead of an English anvil. I think it's a better, cleaner cut, less traumatic. Clean, take it down here, take out everything, use a curette, clean everything out. But I would give this a chance to grow back out before doing a permanent procedure. This one, I wouldn't even mess with. Why would I mess with doing partial? I'll take out the whole nail, use a tissue nipper, clean all this up, silver nitrate, everything that's hypogranular, come back in 2 weeks and see how they do. Why 2 weeks? Well, because the global on this is 10 days. It's a joke. I don't really care about the billing because I work for UHS or UT, But in private practice, you're looking at 2-week follow-up. Let's continue. So in the beginning stage, patients do very well with Epsom salt soaks to have them pull back on the nail fold, use like a, emery board or a metal nail file to shave down the offending border. Now, with patients with like severe ones, once again, I don't like to use phenol. I think it's too caustic and I don't think it takes, and they'll have to come back for multiple procedures. There's always something that remains. So I'd rather just do one, clean it up first and have them come back, monitor, and then do a permanent procedure when it's less inflamed, when it's less red. But yeah, putting patients on antibiotics is a good thing. And a lot of times actually, in case with ingrown toenails, they're not really infected. The redness, the swelling, it's more from the irritation of that ingrown toenail than actual infection. So let's move on to plantar warts, calluses, and corns. They present them very much alike. They do look a little slightly different in terms of plantar warts. The skin lines go through the lesion, weight-bearing or non-weight-bearing surface, pain on lateral pressure, usually younger population. You have calluses, more of a weight-bearing surfaces, repetitive trauma. Now, calluses, pretty easy. Pare them down, whether blade, pumice stone, emery board, soaks. Plantar warts are different. You shave them, they come back. A lot of times they do spread. I love to freeze them. I love to use liquid nitrogen cryotherapy, freeze them. But there's lots of good literature saying that occlusive therapy, like duct tape, works even better. I just like to play with liquid nitrogen, and I do think it's effective. But duct tape is very effective. You cut a piece of duct tape, you put it on the lesion, give it 4 or 5 days, it'll fall off, then use an emery board and continue doing it. And if that does, but I do like to use the liquid nitrogen, but I do think it's very effective. But those are very good, treatments for plantar warts. Calluses, once again, paring them down and using any topical lotion like amlactin, urea 40%. I stay away from salicylic acid because that stuff will eat through, most of the time, those patches. You put them on a lesion, they'll move. In diabetic patients, they're neuropathic, they won't feel anything. They'll eat a hole through the foot. Urea is safer, amlactin is very safe, and they're effective. I use amlactin on my hands. Here we go. Oh, that's not my hand, but it's how I would do it. Yeah, duct tape, scalpel, good. And corns usually tend to be on the dorsal aspect, usually with associated with hammer toes, usually on the PIPJ, padding, cushioning, unless they want surgery. And that's a different story. All right, common foot deformities. Patient comes in and says, oh, I got this nasty bunion. The question is it a bunion or is it an arthritic great toe joint? Then we need x-rays. Weight bearing, 3 views. Okay. The question presents itself as now, are they complaining of it? Is there actual pain or they don't like the aesthetics of it? You can have hammer toes, you can have bunions, you can have flat foot high arches. The question is if they're symptomatic. Lots of patients present like this, but they don't have any issues with it. So be it. I'm not going to doing surgery for cosmetic reasons, especially in the foot, not advisable, or treating something that's asymptomatic. I let sleeping dogs lie. But okay, in some patients, obviously this can be symptomatic and problematic. In cases like this, every patient's different. Obviously, that's a matter of subjective, but if patients don't have any pain, don't worry about it. So you got hammer toes, and they can present in 3 different, well, actually even 4 different ways. You have a mallet toe, which is at the very distal, at the PIPJ, hammering, which is at the PIPJ, and claw toe, where it's actually both the PIP and the DIPJ. The biggest thing with these is it's very common with diabetics, right? Neuropathy causes loss of intrinsic muscle tone. A lot of times you'll see they have hammering to get ulcerations either dorsally at the PIPJ or at the distal tip of the toes. But in younger, healthier patients, usually more common with females because of flip-flops or sandals, their toes they don't have, their toes are grasping to hold on to said, shoe gear. Then another common thing, obviously, pes planus, pes cavus, whether flat foot, high arch foot, same thing. You can have flat feet and have no issues. You can have a high arch foot and have no issues. If it is symptomatic, weight bearing x-rays, bilateral. For a lot of these patients, inserts, supportive shoes, supportive inserts, avoid being barefoot. I'm never barefoot. Only when I shower or sleep, and sometimes I sleep in my shoes just to be safe. So, most common foot deformities. Most respond to conservative management, supportive inserts, padding, offloading, accommodative shoes, NSAIDs. Oh, look, order weight-bearing x-rays to reviews. Little padding. This goes a long way, especially in a diabetic patient that doesn't want surgical intervention. These power step inserts, you can see that I put right here, it says purchased other variation 8 times. These are the ones that I buy off Amazon. These are the ones that are in my sneakers right now. They're $30. I have them in all my sneakers. I do have a pair of custom orthotics because at my TDI clinic, we do make custom. But patients love these. They're very well rated on Amazon and with my patients. I recommend them. I wish I had money in the company, but I don't. But I'm a big fan of these. And for a lot of patients with foot pain, even something like this, $30, patients will do great with them. Foot and ankle MSK pain usually comes in 2 varieties. How am I doing on time? Okay. Oh, okay, we're doing great. Perfect. Foot and ankle MSK pain usually comes into your guys' clinic or my clinic. Either it's like an acute trauma, or an overuse injury, with actually overuse being more common than like the acute etiology. You have your acutes, which are your fractures with or without dislocation, ligament sprains and tears, and tendon issues. But overuse usually typically, develop without an identifiable event associated with symptom onset. So these are your tendinopathies, stress fractures, or ligamentous injuries, can be also plantar fasciitis, impingement syndromes. Usually this presents as, well, in the acute sense, usually it's an ankle sprain. That's actually probably the most common thing that, comes into a PCP clinic, very common in young athletes, older athletes, ankle sprain. But is it an ankle sprain? That's a good question, Dr. Sobolevsky. Well, anytime especially with an inversion injury, I'm going to show a demonstration that, I don't know, you turn your ankle like this, right? Hold on a second. You turn your ankle like this. It hurts. But there's so much in this area. You have your lateral ankle ligaments, right? The AFL, CFL, the PTFL. But you also have your peroneal tendons that run back here. They can get injured. The peroneus brevis attached to the fifth metatarsal base, you can get an avulsion fracture there. When your ankle turns this way, the talus could bump up against the tibia. You get an OCD lesion, okay? Or it could be even higher. You could actually rip this, or you can go into the syndesmotic injury where the pain would be actually a little higher up there. But so there's lots of different issues just with they come in, they think they just have an ankle sprain. It could be lots of different, causes of pain. You could have possibly, usually the medial ankle is usually with an eversion, not nearly as common as inversion injuries. The biggest thing is a lot of times these can be treated conservatively. Obviously, you rise, immobilize, but it could lead to weakness and instability. The biggest issue with this is residual pain, residual weakness, and further on, just having more lateral ankle instability. But at first, order x-rays for an ankle, rest, ice, immobilize. Less common, you do see stress fractures, usually not in our population, but in the athletic population, overuse. Most commonly, it's in the second metatarsal distally by the head, neck. You can't see it in the heel. That's really just chronic repetitive injury. An x-ray is not going to show anything most of the time. You'd need an MRI to see if there's bone marrow edema within the bone, but x-ray is going to be negative. A lot of times the risk factors will be changes in training, activity type, footwear, terrain, age, gender, race, previous injury. And once again, x-rays might not show anything obvious, and sometimes 50% will never be apparent on plain films. And sometimes MRIs can be even misleading. And they'll show up as osteomyelitis. It's like, what? It's a stress fracture, but we'll get to that. So this is the last category, the diabetic foot. You guys know it well. I know it incredibly too well. And obviously we work together in-house, right? With Dr. Falcone, and right now it's Dr. Davis. We see a lot of the diabetic feet, right? So everything that I've said previously about everything, whether it's nails, calluses, ingrowns, plantar fasciitis, pain, that you got to take it somewhat differently with a diabetic patient. Because this unfortunately keeps me way too busy. All right. I can't tell you how many amputations I do, and I hate doing them. I do them well, but I hate doing them. And this is the biggest issue. So it is estimated that up to 20% of diabetic patients require hospitalization. In San Antonio, it's higher. Even a skin ulceration is a serious medical condition. I agree. At least can lead to, amputation. Non-healing wounds lead to a bunch of amputations. And once again, you have to take into full account their, pre-existing conditions, and, take into look into everything. In diabetic foot literature, they really talk about neurosensory dysfunction. I'm not as big into that as I am about vascular perfusion. For me, it's vascular, 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 vascular. If a patient comes in and they're neuropathic, I can't do anything about that, can I? Right? Can I somehow get them to feel things that they can't? I can't. I can tell them to check their feet daily, make sure that they're, not barefoot. But if I have a patient that comes in with poor circulation, I can get vascular studies, send them to vascular, interventional radiology, interventional cardiology for an angio, and we can do something to improve that, right? So for me, pedal pulses are more important than anything else. I won't do a nail procedure on a patient that I can't feel pulses. I won't do a callus debridement if they have poor pulses. If I cut them, God forbid, okay. And we've had patients with ingrown toenails, they'll end up getting a BK because of a negligent workup. It's happened. So for me, okay, sensation, it is important, but for me, circulation. And so here you have your, different diabetic wounds. There's lots of different categories and classification systems, whether based on infection and based on ischemia. The biggest thing, you see a wound in your clinic, you should be able to assess whether, okay, it's infected, acutely infected, if versus like something that's, chronic and stable. I was talking to Dr. Golat here, and he's a former graduate of this program. And he asked me about, wounds and antibiotics. Once again, a lot of these patients don't have time for taking a little wound culture, sending out, waiting, and coming back. If it's a chronic wound, possibly, but in a new wound that has a little pus, I go broad spectrum, get x-rays, MRI if needed. They don't have time for just, let's see if Keflex works. Not with our patients, not in San Antonio. I hit them hard. Chronic wounds, that's a different story. You can't, culture it and then go from there. But usually I go doxycypro, depending, kidney function, resistance, but I try to get everything, clean it up. Obviously, if a patient comes in septic, or if you see, proximal streaking, send them to the emergency room. This is where it is better be safe than sorry. And a lot of times when patients aren't looking good, go straight to the ED. Get labs, WBC, ESR, CRP, advanced imaging, go from there. I'd rather send a patient to the hospital, have them wait 12 hours to get an MRI, get all their labs done, get a couple of treatments of IV antibiotics, and have them lose a foot. And once again, better be safe than sorry. So now we have another condition with diabetic foot called the Charcot foot. It presents a lot like cellulitis, right? Red hot swollen, but it's not an infection. There's two different theories on why it's, there's the vascular component or a neuropathic component, but needless to say, on x-ray it shows like everything's broken down. But it's not an infection. On MRI, it'll show that there's osteomyelitis everywhere because there's bone marrow edema, there's fragmentation. This isn't an emergency in the truest sense, but the most important thing is if you see something like this in clinic, and you're like, once again, it should be localized to the foot or foot and ankle, offload them immediately. Because the more they put pressure on it, the more the foot breaks down. If, once again, the fact that it does mimic infection, if you are concerned about it, then you send them to the ED for a full workup. But a lot of times you see there's no trauma associated with it, or sometimes a trauma can cause it. They'll turn their ankle and boom, the whole midfoot breaks down. Well, it's not going to be cellulitis. And once again, San Antonio, it's got to be the Charcot capital of the world. Pretty certain it is. And they get this rocker bottom deformity. But it's not if you want to be safe, send them to the ED for a full workup. Other than that, just offload. Offloading is a great thing for general wounds and things of that nature. But in the case of a Charcot foot, and something even like this, a lot of times there's 3, 4, everyone slightly different, 3 or 4 stages of Charcot. But this will stabilize. And it's good to check the contralateral foot for warmth. But a lot of times patients like this do well. They can't feel any of this. I'm telling you, they'll break down the talus, the calc, the rest of the midfoot, but they just, in a healthy person, this would be incredibly painful. In a diabetic patient, they don't feel a thing. Diabetic foot. Once again, this is where circulation is, for me, is the most important. You have a patient, check their, DP up top, PT behind the medial ankle. If it's not possible, if you have access to Doppler, use it. Non-invasive studies. I think the newest guidelines recommend a yearly NIV, yearly NIVs. I've had patients who within 4 or 6 months, their numbers completely changed. If a patient's complaining, like, I get cramping, their foot is cold, you got to make sure that it's not critical limb ischemia, because that's a dire emergency. They'll lose their whole leg. But in patients like this, you can already see, like, I always, ask students, what is this structure? Well, that's a calcified vessel. And in a patient like this, you can almost see the bifurcation of there's the tibial artery, and you can see the bifurcations actually here from the A to the DP right through here. That's not good. All right. And once again, we have three departments that is willing to address these issues, whether vascular, whether interventional radiology, whether interventional cardiology. They'll all be willing to do angios. Some more than others, but they're all willing to do them. All right. As my references, but I'll go back to this. The diabetic patient, a lot of times in terms of pain, they do have pain, whether it's neuropathic pain, whether it's vascular pain. Neuropathic pain, there's not much I can do for it. We get consults for neuropathic pain. Well, a lot of times they're already on gabapentin or Lyrica. What am I forgetting? Bingo. But there's not much I can do for it. It's irreversible. It's there. I tell them, oh, tight glycemic control. There's not much I can do. A lot of times they come in that, it looks like heel pain, plantar fasciitis. It's not. It's a mixture of whether it's neuropathic or vasculopathy. Because a lot of these patients, especially long-standing diabetics, they will have pain from just PVD. And that's the first thing that I check. I'm telling you, circulation is more important than anything. Before you do anything, check your vascular studies and go from there. And unfortunately, the population is now getting younger and younger. Since I started here, I'm telling you, I think the average age of diabetic foot conditions, like amputations, probably gone up by 5 years. Currently in-house, we have the 2 35-year-olds, a 40-year-old, these, and we're the gatekeepers of us, being able to stop this from happening. And that's why I tend to be more conservative in terms of patient follow-ups. If a patient has a wound, I immediately start with wound care, and if needed, infectious disease. But I tend to be very conservative in this because my job is to save and not to cut. Unfortunately, I have to cut a lot, but that's where you guys come in and I come in. It's a multidisciplinary approach to trying to save these, limbs. And that's the last point, I guess. A lot of times, especially in-house, you'll have a patient with an infection, a bone infection, osteomyelitis. And if we refuse to do anything because of PVD, but then infectious disease wants a biopsy, it's really hard to do a biopsy on a patient that has severe PVD. Why would I create a wound to take a bones biopsy? Because now I'm adding an insult to injury. Now, if it's stable, okay, osteomyelitis is not a diagnosis for admission or surgical intervention. You can manage it with antibiotics, or you can manage it by serial monitoring. I have patients that I see every, 3 to 6 months that I get repeat x-rays just to make sure everything is stable. I'm not going to do a biopsy on a patient that has poor perfusion. I don't want to create a wound, and I don't want to cause an issue where there wasn't one in the first place. But I think that is it. I want to thank you guys for your time and inviting me to give my little spiel. Now, mind you, this is where I'll say these are my tips and tricks and the way I do things. Some people do it differently. But if I I stand by my results, and I do change things like I did with my plantar fascial injections. I change things up, but I researched carefully and I discussed with other providers and other specialties, make sure that, you know, I'm staying ahead of the curve, but I get good results and I stand by them. And needless to say, thank you very much, guys.
Any questions, comments?
So just thank you for that outstanding grand rounds. Just as a small thank you, there's our family community medicine coin. So if you're over in the military, you know that people have their unit coins.
Mhm.
This would mark you as an honorary family physician. This is the highly sought after, seldom presented, but always treasured family and community medicine challenge.
Thank you very much.
Thank you.